I'm delighted to be here, and that so many familiar faces are in the audience, not least including my mum and dad, who have been with me since pretty much day one. I say pretty much because my dad was actually day two, but he assures me that was just a generational thing. I'm hoping that in 45 minutes' time they'll have a much better idea of what I've been doing for the last 20 years or so. I imagine that the first task for me in preparing this inaugural lecture was to construct a compelling narrative bringing clarity and coherence to a series of deliberate career choices that I have made and which have successfully brought me to this very point. But alas, my own research experiences, as I will explain, have not followed a nice, neat, carefully planned path, and so that proved a little challenging. However, as I look back, two general themes did emerge. Firstly, a consistent interest in studying change in healthcare organisations, starting with my PhD, as Helen mentioned, at the University of Southampton in the late 1990s, which explored how the NHS adopts new technological innovations. Before I moved on to evaluations of quality improvement interventions during my time at the Health Services Management Centre at the University of Birmingham, and then such evaluations broadened out into an interest in organisational behaviour and organisational development, following another move, as Helen said, to University College London. And since 2005-06, a particular focus on improving patient experiences of care. In addition to this interest in change, the second and clearest trend has been my move away from traditional summative forms of evaluation, making judgments on relative effectiveness, marks out of 10 type evaluations, to more action-oriented, formative research, seeking to both capture learning at the same time as making a difference to practice. And as I reflected on this, I began to wonder, where did this preference for more formative approaches take hold? And I realised it began here. This is a photo of me and my mum in Guernsey in 1970. This is the Bonnie Baby of Guernsey competition, which on first viewing probably looks like quite a happy picture. It would be reasonable of you all to assume that you're looking at the winner of the Bonniest Baby in Guernsey competition 1970. But if you inspect the photo a little closer, you might just begin to detect my eyes are a little watery. You'll see the pursed lips, the clenched jaw, because that is not the trophy for the winner of the 1970 Bonniest Baby in Guernsey competition. That is the trophy for the runner-up. An independent panel of judges had determined that there was a Bonnier Baby on Guernsey in 1970. And I think it was at this very point when I was handed this trophy that I began to turn away from summative forms of evaluation. I should point out that's not a wig, that is actually my hairstyle in 1990. Inaugural lectures are at least part ritual humiliation, I think. This is me graduating with my degree in modern history and politics from the University of Southampton. And I followed the time-honoured tradition of history graduates in terms of my next career step, which was the job centre in Woolston, one side of the Southampton Bridge, where I spent 4 months signing on and following Southampton Football Club around most of the country. And then just before I was going to go cap in hand to my parents to pay my airfare to return back to Guernsey, I somehow managed to land a job here, which I don't think there's anyone else here will probably know where this is, but they might do. This is Dawn House. This is on Sleepers Hill. This is just outside Winchester, and it's where the Wessex Institute for Public Health Medicine, part of the University of Southampton, used to be sited. It's a private house now. And as Helen mentioned, the Wessex Institute for Public Health Medicine won the contract to coordinate the Health Technology Assessment Programme, which is now grown and developed into the NIHR Health Technology Assessment Programme, still based at the University of Southampton. This is my first proper job, working for the HTA programme, writing commissioning briefs for health technology assessments, conducting my own health technology assessments of different interventions, drugs, etc. And the office that I shared with several other researchers was the one in the eaves room on the left, and you can see there's a little balcony out the back there, and you could sit on that balcony, look out across the Hampshire countryside, and on a clear summer's day see the Isle of Wight, which was very nice. And I stayed there for 4 or 5 years, and then for reasons that I'm unable to now uncover, I decided to move here. This is the brutalism of Brunel University, where Clockwork Orange was filmed, of course. And I moved there, and I worked at the Health Economics Research Group for 2 years. A very enjoyable time. I was living in central London, but the one thing I learned from those 2 years was that I did not want to be a health economist. And so I quickly followed another move to Birmingham, where I worked at the Health Services Management Centre. And that was a key moment in my career, as I'll come on to explain. But I spent 2 years there at the Health Services Management Centre before moving to University College London, which, as you'll know, has a beautiful campus in Bloomsbury. It also has a campus in Archway, just opposite the Whittington Hospital, which is where I was based for 6 or 7 years in the medical school. And when I was putting these slides together, and I look back now at those moves, I do begin to think that my career was heading very much in the wrong direction at that point. But I got back on track. And I moved to King's College London in 2008. Actually, it was 2008. I got my chair in 2011. So I moved to King's in 2008. This is the view from my office. This is the IMAX cinema just outside Waterloo. And I've absolutely promised myself that I'm not going to say that my career has been a long and winding road, a magical mystery tour, or that I've had to work 8 days a week to get here. What I'm going to do for the majority of this presentation is talk about experience-based co-design, but I did want to highlight a few other projects that I've been involved with, which I think are worth mentioning and reflecting on. One was a piece of work that I did when I was at University College London with Trish Greenhalgh and others on the diffusion of innovations in health service organisations, which is probably still is the most cited of any project that I've ever been involved with. It was a very small grant from the NIHR systematic review. I think Trish gets 80% of the royalties from the book, and I think that's probably a fair reflection on where the academic credit should go for the work. There were 5 or 6 authors, but it was really very much Trish's baby. Also, while I was at University College London, I did some work with Paul Bate, and more about Paul in a moment. But this particular piece of work was bringing social movement theory. So how do social movements like peace movements, environmental movements, how do they generate energy for change on a very large scale? And can we learn something from social movement theory and apply it in an organisational context? And this was very much around the context of the time of the NHS plan, where we were looking for large-scale improvement interventions. Another piece of work with Paul, but also with Peter Mendel, a social scientist based at RAND in the US, was around organising for quality. This was a study we did of leading hospitals in the United States and Europe, where we were looking to see how they'd managed to sustain quality over significant periods of time. What were the challenges they'd faced, and how had they responded to those challenges? And we published this book on the basis of that. And that work has had something of a legacy in terms of a project which is just about to finish, the Quasar Project, Quality and Safety in European Union Hospitals. This is, building on the Organising for Quality work, testing and extending the frameworks and findings in that original piece, but testing it this time in 5 European countries, in 2 hospitals in each of those countries. And that's a picture of the Quasar team. Naomi Fulop, who was at KCL, now at UCL, is the PI. And you can probably just see Janet Anderson peeking around the side, on the right-hand side of the photo, Janet from the school. Janet and I both lead a work stream in the Quasar project, which is going to be finishing in just a matter of weeks. So those are projects that have all been very important in terms of my career, and they've all certainly influenced my thinking. But what I wanted to do was to talk specifically about experience-based co-design and the origins of it. And I think it probably starts here when I moved to the Health Services Management Centre at the University of Birmingham. I met up with someone called Professor Paul Bate for the first time, someone I hadn't heard of or met before. And my first research project when I moved to HSMC was to evaluate something called the Orthopaedic Services Collaborative. Paul had written a tender and had been appointed to be the evaluator of this collaborative. As I said, this is all very much at the time of the NHS plan, around 2000, 2001. The US Institute for Healthcare Improvement, headed by Don Berwick, whatever happened to him, lots of the quality improvement interventions they developed in the US were being brought over to the NHS. And one of them was this notion of breakthrough collaboratives, where clinical teams from different hospitals would come together with a shared goal, for example, reducing length of stay. They would attend a series of learning events where they'd be taught about quality methods, different approaches to change. And then they'd go away after those learning events, back to their hospitals, make changes, and then come back to the next learning event, sharing their experiences and their results. And we were asked to, we were appointed to evaluate this, and in Paul's research tender, the successful research tender, he wrote, "The Health Services Management Centre evaluation team might find itself sitting on data or insights that might make a difference, indeed might even help prevent the project from failing or underachieving." He went on to say that one option would be for us to take a formative approach to feed back our qualitative findings as we go, so that the course of the collaborative could be amended or changed as appropriate. And this was the response that we got back from the member of the central team that was leading that collaborative. "We are in danger of confusing roles and of wasting our precious time. It's rather like seeing someone being knocked over by a bus. Do you write to your MP or give him mouth-to-mouth resuscitation? We now have to accept the bodies on the pavement scenario." So a very clear rejection of a formative approach to evaluation. This was a high-profile quality improvement intervention being imported from the States. There was quite a lot riding on it. There were plans for there to be collaboratives throughout the NHS in different clinical services. And they wanted a summative evaluation. Does it work or not? Should we invest in this? As Paul and I later wrote about in a couple of reflective papers, there's something of an irony of this non-learning evaluation of a learning-based quality improvement approach. The whole structured approach of collaboratives was around these learning events and teams coming back together and sharing learning as they went. But that wasn't the approach they wanted for the evaluation. But sure enough, as we began to collect our qualitative data in the early stages of the collaborative, it was a 12-month program, we began to get this type of feedback. So from one of the project managers. "The method is incomplete. It says that if you measure and monitor over time, and if you are clear about your objectives and who's doing what, you'll get there. What we are looking at is not as simple as that. You've got to change what people do and their habits, and that requires something extra, not in the method." And then perhaps more directly, a project team manager member in month 4, "I think our team has struggled to see how the change method can actually be applied to some of the things we want to look at. The central team are absolutely hung up on it. They think it's the be-all and end-all, and it's absolute twaddle." So Paul and I spent 12 months collecting this qualitative data. It was getting increasingly hostile towards the members of the central team and the way in which the collaborative was being implemented. So metaphorically, the bodies were really piling up on the pavement as far as this quality improvement intervention was concerned. And in the end, at the end of the collaborative, 7 of the 38 participating trusts failed to complete the programme. 50% of the original project managers failed to stay the course. And the outcome data that were reported were too incomplete, non-standardised and simplistic to form the basis of a robust assessment anyway. So what we were left with was we really didn't have very much to say about whether it was a good or bad method, because it had all failed in the implementation. It had been implemented really badly. We couldn't draw generalisable lessons around the collaborative. And anyway, by the time we came to publish our summative report, there were collaboratives springing up left, right and centre in any case. These were all starting off, and they hadn't built on any of the learning or lessons that we could have perhaps offered from the orthopaedics collaborative, which was the first evaluation of its type. So the question Paul and I were left with after this experience of a very summative evaluation was, are we just howling at the moon with these types of evaluations of quality improvement interventions? Are we actually ever going to make an impact? So, as I say, we went away, we wrote a couple of reflective pieces about our experiences of evaluating the orthopaedics collaborative. And then we began to work much more closely with someone called Helen Bevan, who was the Director of Service Improvement at the NHS Modernisation Agency, then became Director of Service Improvement at the NHS Institute for Innovation and Improvement. And Helen was a big advocate of all of the IHI work. She was very supportive of their interventions. But she had begun to think that just continually having more and more of these top-down programmatic approaches to change, they were bringing about sort of incremental first-order change, but they weren't getting the large-scale change that the NHS plan needed around transformation. Were there different ways we could think about change that we should introduce into the NHS that weren't so reliant on these programmatic approaches? And so she gave Paul and I a little bit of money to go away and think, just do some sort of blue skies thinking about where might there be different approaches. And we came back with 2. One was around the social movement theory work, which I mentioned earlier, and which I still think is a very rich body of work that we haven't tapped as much as we could have done. But the other was around design sciences. How do designers, graphic designers, software engineers, architects, how do they engage with their users at a very early stage of the design process to develop services and products that are going to meet their needs? Might the design sciences and their way of thinking help us close this gap between research and practice, making the knowledge that's generated by evaluations much more actionable, much more relevant and useful to practitioners? Helen thought this was interesting, and she's told us to go away and come up with design and intervention, which we should then pilot, and she said she would fund that. And one of the models that drove a lot of our thinking at this stage from the design sciences was this notion that designers have that any service or product has three components. It has to be efficient, it has to be safe and reliable, but we also need to think about what does it feel like. And it's those three components, if you meet each of those, that will produce a good service or product. And when Paul and I saw this model, the thing that occurred to us was that the NHS was spending an incredible amount of resources and time on the performance efficiency issue, so anything to do with lean, anything to make services more efficient. There was lots going on in that respect. As far as engineering was concerned, there was lots going on around patient safety, and there is even more going on around patient safety now in the NHS. So things like the Safer Patients Initiative. But where were people addressing this third component around the aesthetics of experience? What does it feel like to be a patient in the NHS? And that had two components around not only the physical environment, but also the human environment, these relational aspects of care. And this is where we came up with the notion of experience-based co-design. Could it help us meet this third component of what a good service is? And it's not saying that performance in engineering isn't important. Of course they are. It's just saying that you need to pay attention to the third one as well. And we felt at that time, this is around 2003, 2004, there wasn't much going on in the NHS in terms of the quality movement around patient experience. So we developed an intervention, and we found a case study site, which was Luton and Dunstable Hospital. And we began work with their head and neck cancer service. And actually, in preparing these slides, I've forgotten about this photograph, but this is the photograph of the project team that worked on that original pilot. That's me at the top, Paul's on my left, Kate Jones, who was Director of Service Improvement at Luton, Deborah Shebeko, who was a designer working for a design company called Think Public, who had given us the design lens and guiding our thinking, Lynn Marr, who's a colleague of Helen's at the NHS Institute, who was the project sponsor for this pilot, then Elaine Hyde, who was a service improvement facilitator at Luton and Dunstable then, but is now the Director of Quality at Luton and Dunstable. And then you can just see the forehead of Ivo Gormley, who was the filmmaker, because this is a very narrative-based approach, and it's a filmed narrative-based approach. We capture patients' experiences through filming them talking about their experiences of services. So what we came up with, this thing called experience-based co-design, a participatory action research approach that combines a user-centered orientation, that's the experience-based bit, so a relentless focus on the experience of users, patients, carers, and a collaborative change process, patients, carers, and staff working together to actually implement improvements and bring about changes. And it had a typical kind of participatory action research cycle feel to it, so 6 stages, starting at 1 o'clock with setting up the governance and the project team, etc., ethics, all of that type of stuff. Then engaging staff and gathering their experiences through semi-structured interviews and, importantly, through non-participant observation. 3rd stage, engaging patients and gathering experiences. And as I mentioned in this original pilot work, we used a filmed approach, gathering their narratives, and then feeding those narratives back to a group of patients so they had some shared reflections on what their experiences were and what their priorities were for improving the service. Then a co-design meeting when the staff and patients come together for the first time, and I'll show you in a moment what happens at that co-design meeting. And then having identified the small number of priorities that they want to work on together to improve services, patients and staff then form small co-design teams and actually get on with the implementation of change. And then a celebration event at the end to report on successes and achievements, and the cycle begins again. So those are the 6 broad components of experience-based co-design. And these are some of the pictures from the original fieldwork. Paul speaking to the Max Fax surgeon to the head and neck cancer service at Luton, John Pickles, the clinical director, Paul either doodling or taking some notes. Anthropologists do lots of doodling, I'm not sure which he's up to there. And then a nice stage photo of me doing some interviewing with some of the staff members. So having engaged with staff and fed back to them and heard what their priorities are for improving the service, we then engage with patients by getting them to tell their story. So in this pilot work, we interviewed, it was around 16, 17 patients. I went to their house, I filmed them, I interviewed them talking about their experiences. We sent them a copy of that DVD. And then we brought them all together, and they watched excerpts of each other's films, and then we took them through various exercises where they could share their reflections on their experience of their service. And they could identify the points in the service where they'd had a good experience and points where they wanted their experience to be improved. And so we got a sense of what different emotions they were feeling at different points on their pathway of moving through this head and neck cancer service. And what we're looking for when we're going through these exercises are what designers call touch points. And these are the critical points, the big moments, good and bad, the moments of truth, the emotional hotspots, that when they reflect on their experience are the things that have really shaped how they felt about that service. So just to give you some examples from the original pilot work with the head and neck cancer service, one would be the breaking the bad news moment. Obviously, the news when you're diagnosed with cancer is a key touch point for patients. Others, perhaps less obvious ones, the mirror moment. So these are head and neck cancer patients who have quite major surgery, and often they were seeing themselves for the first time post-surgery in the mirror. They're supposed to be accompanied, but we were finding that most often they were by themselves when they saw the results of the surgery for the first time. Another would be the fitting of the radiotherapy mask. Lots of these patients would go on to have radiotherapy, and that was a clear touch point for many of these patients. And the final one, which came as a real surprise to staff, was the PEG feeding tube. So these patients would go through quite major surgery, lots of courses of radiotherapy, and then they would have to be fitted with a PEG feeding tube. And for the staff, they felt this was a fairly trivial procedure, given everything that the patients had gone through previously. But for the patients, they would talk about it as the moment when the cancer became visible and the last straw. So those are what we mean when we talk about touch points, these moments that patients reflect on as having really shaped their experiences. So then we moved, so having captured all of those staff and patient experiences and fed back to them and heard what their priorities were individually, we bring the patients and staff together in this first co-design meeting, where the staff get to watch the film with the patient interviews, they hear what the patients have prioritised, the patients get to hear what the staff have prioritised in terms of how they would like to improve the service. And then, again, through facilitated exercises, patients and staff agree on what their shared priorities should be. And they form working co-design groups to make these improvements. And this is an example from the initial pilot work. One of the touch points was around the first visit to the outpatient clinic. And you can see here that some of the patients and staff have written about it's the gateway to what follows, it's frightening. And then they needed to have accessible water, refreshments, separate reception room, more privacy, those types of things. So in this particular pilot work, as a result of those shared discussions at the co-design meeting, 6 co-design teams were formed, comprising patients, carers, and staff. And the service improvement facilitator, Elaine Hyde, who you saw earlier, logged that there were 70 actions taken across these 6 co-design teams, leading to 43 improvements in this particular head and neck cancer service. And examples would be moving the weighing scales from where they were in the outpatient clinics, that patients were no longer embarrassed when they struggled to get on the weighing scales, they had to take their shoes off and all that type of thing. A staff training needs analysis on the post-surgical ward. There were lots of issues around the patient experience on the post-surgical ward, so a staff training needs analysis was carried out. I mentioned around the PEG feeding tube being a clear touch point and patients wanting more information about that. And also, an example I'll say a little bit more about, the physical environment in the outpatient clinic, going back to that the previous slide where you saw that was identified as a priority. So one morning when the outpatient clinic wasn't being used, the patients and the staff came in together and began together to actually move the furniture and change the physical environment of the outpatient clinic. And there's a lovely quote from one of the staff members who took part in the project. It was quite funny to see them lifting up their chairs. I think that becomes a symbol of the project. It's a symbol of the project that those chairs are those patients' seats. And it's about the staff and the patients together, just moving everything around. So it becomes the symbol for the whole project. So I'm just going to play you a very short clip now. This is some of the staff and patients who took part in this original pilot work talking about their experiences. And this clip is about 6 or 7 years old now. It's taken on the field, to me at least, quite a sort of historical document. So the quality of the video isn't the best, but I think it will give you an illustration of what it's like to take part in these types of projects.
And it is new, I've not come across it before, where we've actually involved the patients in that way of improving services for them. But I think it's definitely a positive thing having all this work going on.
My own view is that this is an organisation philosophy. It's about an approach, and the partnership between patients and staff should be a principle behind every improvement project.
But I've been very pleased with the amount of involvement that we've had and how collaborative the whole experience has been.
I've had the surgery, I've had the treatment, but I'm not forgotten, It's like belong to society.
I've been really impressed to witness the patients in the same room as the professionals delivering care, and seeing the interface with them in a completely different light. Just seeing them talk to them as normal human beings, not as the paternalistic doctor-patient relationship. And I think there will be tremendous dividends from that for the whole health service.
And I can't get over the fact that the staff didn't need to become defensive about anything. The consultants turned up, and the charge nurses, and the people from reception, and the patients, and we were all together, and there was that terrific sense of it's an equal playing field. Anybody could speak. There was no sense of fear. There was no hanging on status or using it. It was quite incredible, really.
I've been very pleased to work with it. I'm quite happy to continue working with it.
I think it's actually been is a very powerful, more than an exercise, it's almost like a movement.
The collaboration movement.
I think it's given us the opportunity to hear what patients really think about the way we're delivering services.
Okay, so with those types of reactions, we felt we had some sort of proof of concept. I mean, this has been quite a labour-intensive pilot. We've put quite a lot of resources into it, and we've made lots of mistakes. But it seemed as if there was some value here, and it felt different to staff and patients to take part in this type of project. I want to share this with you now. This is my favourite photo of Paul Bate, who I'd met at Health Services Management Centre. It's my favourite photo for a couple of reasons. And I can say this because I know he's on a driving holiday in Arizona, so he can't be here today. The first reason is some of you may have gone to Martin Marshall's inaugural lecture at UCL a few months ago, where Martin was talking about this gap between the ivory towers of academia and the swampy lowlands of practice, and how it was so difficult to fill that space and to bridge those two worlds. And when he said that at his inaugural lecture, I thought about this picture. And the reason I thought about this picture is because Paul is the best person I've ever worked with for bridging that gap and for being able to look both ways, to research and to practice and to bring them together. And this picture just occurred to me. I don't know whether he's on the safe shores of academia looking out to the stormy waters of practice, but for some reason this picture came to mind. The other reason why I like this picture is because it gives me a link into the next stage of the EBD story, because this picture is taken in Wollongong, about 2 hours south of Sydney. Paul and I have been engaged to work on a 3-year formative evaluation of a clinical services redesign project in New South Wales. And while we were down there, in the usual way, we got invited to give some seminars and lectures and things. And we gave a lecture on the experience-based co-design pilot at Luton. And as a result of that, it got picked up by someone called Jane Gray, who was at New South Wales Health. She was leading on their patient public involvement work. And she said they'd like to try experience-based co-design in Australia. So they implemented the approach in 7 hospitals, in their emergency departments in these 7 hospitals in New South Wales, in 2 stages. The first stage, Paul and I mentored project teams in 3 emergency departments, lots of teleconferences at 5 and 6 o'clock in the morning. And then in the second stage, they rolled it out to 4 further emergency departments, where they were partnered with another department, because they were interested very much in the transitions between emergency departments and other parts of the hospital. And this was our first opportunity, really, to see how, when people took this approach that we'd piloted at Luton, how implementation varied once people had heard of the approach and had taken it up. So we saw quite a lot of variation in terms of the number and type of patient interviews that were undertaken, the number of type of staff interviews, and the amount of observation that was done. As you can see, in some of the hospitals, they didn't do any observation at all. I'm not going to go into too much detail about the Australian EBCD projects, but I just wanted to share this because I think one of the things that concerns me when I hear about EBCD projects now is that quite often people really play down the value of the observational work. And I think there's some great examples from some of the projects that have used it. about how it can really lead to some very reflective learning spaces and practices for staff. This is a picture of the reception at the emergency department in Bankstown, a hospital, which is in the eastern Sydney. But the really interesting thing is, as well, always thinking about the staff perspective. Not only have the patients got a terrible experience of checking into that ED, but the staff haven't got a great experience of meeting the patients at reception either. So the value of observation, I think, is crucial to this type of approach. The 7 emergency departments in Australia, they found various common improvement priorities were around patient and carer comfort and privacy, physical space for staff and patients, communication and information flow. And there's a whole range of solutions that were implemented in the 7 emergency departments. You can see some of them here. A designated nurse to manage the waiting room and communicate with patients, informed waiting training for all staff, and physical redesign so that the triage nurse and the clerical staff do actually have a clear view of the waiting area. Fortunately, New South Wales Health commissioned someone to do an independent evaluation of the experience-based co-design projects in Australia. It was Riccadema's team at the University of Technology in Sydney. And they came to a couple of conclusions, which I just wanted to share. One was that the primary strength of EBCD over and above other service development methodologies was its ability to bring about improvements in both the operational efficiency and the interpersonal dynamics of care at the same time. And I think if you reflect back on that, that equation that we've taken from the design sciences about the importance of addressing performance engineering and the aesthetics, this rings true in this quote where they're talking about we're getting both that efficiency but also interpersonal, relational aspects of care. And the other conclusion that they drew was that EBCD teaches project staff new skills. It enables frontline staff to appreciate better the impact of healthcare practices and environments on patients and carers. It engages consumers in deliberative processes that were qualitatively different from conventional consultation and feedback. So this is very different to just using a patient survey or real-time device. This is about drawing very directly on patient experiences, but within the context of a change process. So really going beyond the metrics and actually involving patients and carers in co-design and improvement. So we got to the point where we'd had the pilot work in Luton. Seems to have gone pretty well in Australia in these 7 EDs. There was some variation in implementation. We published a book about it, drawing on the case study at Luton and a couple of papers. And then when I moved to King's in 2008, one of the first projects I got involved with was an implementation of experience-based co-design across breast and lung cancer pathways in both Guy's and King's College Hospital. Vicky Zianakis, who's here, is the lead author on the paper. And this was an important implementation because out of it directly, through the work of Catherine Dale and Gina Goodrich at the King's Fund, we developed this King's Fund toolkit for practitioners. So Catherine Dale, who was the facilitator of the breast and lung cancer project across Guy's and King's, worked very closely with Joanna and developed this toolkit, online toolkit, free to use, in 16 sections. There's lots of video clips of patients and researchers and staff talking about their experiences, lots of tips about how to do experience-based co-design. And the website, the toolkit, gets about 3,500 hits a month. There's one of the other pages. That's Vicky, teaching people how to interview and film patients. But one of the things, this was launched in August 2011, and we've learned an awful lot from subsequent implementations since then. We've also done an international survey of experience-based co-design projects. I'm going to share those results with you in just a moment. But we've also begun to test some adaptations of the approach. So we had a lot of learning since we originally did this toolkit. So we're actually in the process now of revamping the toolkit, and we're going to relaunch it at the end of the summer with all of the lessons that we've learned from the subsequent implementations and more evidence and references, etc. But I just wanted to, this is a world premiere. This is a brief taster. This is the clip that's going to go out to try and attract people to this revamped toolkit. It's quite short, but...
I had an experience of surgery recently, and it was very different to my previous experiences, and a lot of the things that had changed and become more positive were things that had had been discussed in the group I was in. So I thought that was fantastic. You know, it's like this has really worked. It's made a difference.
At times, the ideas that they came up with, their solutions and their thoughts about how things could be resolved were so straightforward. We make things very complicated sometimes, and the things that we thought needed to change often weren't the key priorities for patients, and that's what made a huge difference for me.
I think it was one of the most exciting and precious pieces of work I've been involved in.
The most amazing thing was to actually see patients, relatives and staff working together, and the catalyst and the energy that produced.
I think it was an encouraging experience for them. We made them feel, yes, do complain, do say that we got it wrong, because without you saying that, we'll never get it right.
Definitely the King's Fund Toolkit was vital in our understanding, and it provided useful information, how to run the meetings, what the methodology was, what worked, what didn't work. So that was key. So definitely I'd point people to the King's Fund website.
So that's the taster that's hopefully going to tempt people in to come and see the revised toolkit that we'll be launching later in the summer. I mentioned the international survey. So I was aware over a number of years about all of these EBCD implementations going on. People were getting in touch, but I had no sort of systematic view of where they were happening and how people were adapting, tailoring the approach. So with Dr. Sarah Donetto, a colleague in the school, we're just about to complete an online survey of all of the international EBCD projects. So I'm going to show you some of the early findings. The survey doesn't close until the 10th of June, and the results I'm going to share with you are from last week, so they're not quite bang up to date. But in terms of where we found experience-based co-design being implemented, and the important thing to note is that each of these implementations, you can trace a direct route back to the 6 of us sitting in that room in Luton and Dunstable planning the head and neck cancer pilot, either through Paul and I going to Australia and talking to people, the King's Fund website, or the NHS Institute, who funded the original pilot, developed their own materials and publicised those and ran one-day workshops. So each of these implementations can be traced back to that initial pilot work. And so from the survey, there's been 8 implementations in New Zealand, 3 in Australia, 2 in the Netherlands, 5 in Sweden, 25 in the UK, 1 in the States, and 6 in Canada. And my own sense from looking through who's responded and who hasn't responded and what I know about previous EBCD implementations is we're probably capturing about 60% of all of the EBCD projects, I think, in this survey so far in terms of the responses we're getting back. And many of these implementations are in more than one service or hospital at a time. So I've mentioned the work in New South Wales across 7 emergency departments. There's been lots of work in New Zealand. Hilary Boyd and colleagues have done some really fantastic work in adapting the materials and producing their own co-designed toolkit. In Canada, there's some work working across a whole healthcare system with 12 healthcare social care organisations. And tomorrow I'm going to the Netherlands, where CBO, which is the Dutch Healthcare Institute for Improvement, are reporting on a recent project that's just completed working with 5 Dutch hospitals that have used EBCD. The interesting thing for me is to find out more about how they've tailored and adapted the approach and how that's impacted on their outcomes. So I'm just going to share with you some very high-level results from the survey. So in terms of when did these EBCD projects start, you can see that 2005 is the original pilot work that we did in Luton, and it's been sort of increasing ever since. We know that from the survey that there's at least 8 other projects that are planned to start in 2013. And we asked some sort of high-level questions around, do you plan to use EBCD again? About 50% of the respondents saying yes, definitely. 30% yes, but nothing definite at the moment. How helpful, Joanna's here and hasn't seen these results yet, but, so she'll be pleased that her afternoon could have gone in a very bad direction if these had been the opposite results. So how helpful did you find the King's Fund Toolkit? 52% very helpful, 43% very helpful. I'm just giving you high-level results. We've got lots of detailed open comments and much more specific comments about which of the sections need to be improved, what additions would you like to see to the toolkit, that type of thing. Also, we asked them about which elements of EBCD did you implement in your project, which is perhaps the most interesting for me. And I guess a couple of concerns would be only about half using observation, only about half using the going through to a celebration event. Suggests to me if people aren't getting to that end of the celebration event, that it's probably not using it as a cycle, they're using this as a time-limited project. But I think there's lots of nuances and subtleties beneath these survey responses. So we're going to do some follow-up telephone interviews with a sample of these projects. For example, on the patient interviews, 83% are saying that they do patient interviews, but from the open comments, it looks like only about half of them are actually filming the patient interviews, and I think film has a crucial role to play in the approach. The thing that I thought before we did the survey was that people would say, I was really surprised that 90% are going on to do the small co-design teams, because the co-design bit is the bit that people find really challenging, and that was the bit that I was really worried, the element that I was worried people would be missing out. But it seems as if, at least in terms of the survey responses, that people are going through to that co-design stage. But we'll find out more when we do the telephone interviews. I wanted to, coming to the end now, I just wanted to say a few things about projects that have gone on in the school since I arrived, which I've had varying degrees of involvement in. The first one I've had very little involvement in, the web project, which many of you will know about, Wound Care for Epidermolysis Bullosa, Patricia Grocott and Becky Blackwell's work. Secondly, a project funded by Dimbleby Cancer Care looking at enhancing the role of carers in the outpatient chemotherapy setting. And then the final one that I want to say a few things about, a new version of experience-based co-design, accelerated experience-based co-design. So the web project, taking a co-design approach, beginning in 2009. This is for patients with a rare skin condition who need extensive bandages. And this is work that Trish Grocott has led. 4 workshops in 2009 with patients, carers and staff. That user group sets the improvement priority, in this case a replacement for bandages to hold dressings in place. Working with clothing designer and a knitwear manufacturer to develop these new garments. And then a couple of years of developing prototypes, surrogate testing, proof of concept with users. And then by just this May 2013, the new garment that was co-designed by the patients listed on the drug tariff and adopted by the NHS. And as many of you will know, Trish won the Outstanding Research Impact Award from the Guardian University Awards this year for all that work. And it's led on in part to Trish and I being involved in an NIHR-funded health technology collaborative looking at wound prevention and treatment, where we're trying to bring this user-centric co-design approach to everything that goes on in that collaborative. The other one I briefly wanted to mention, the second one, was around the Dimbleby Cancer Care project, which is looking to support carers who are looking after patients who are having outpatient chemotherapy. It's a project led by Emma Ream, Vicky's involved, and Rebecca Verity from the school, and others. And we've used a co-design approach to develop a leaflet and a DVD for carers to support them. You can see some of the sections here with the DVD around relationships, managing side effects, etc. And this is one of the quotes from the process evaluation about the DVD that we've produced. So one of the carers saying, "Without the DVD, I would have felt inadequate and in some sense a failure, and there would be guilt and all this stuff. I got the message of the DVD about how difficult it all was, but nevertheless, people get through it. In fact, the actual carers who were on the DVD were good, particularly the lad who was frazzled but clearly also coped. So seeing that young lad and how he coped, sensing the pressure he was under, helps me to cope." But I think the important point I wanted to make about the Dimbleby project was that we haven't just used co-design to develop a new information leaflet and a DVD. We've used co-design to come up with the process by which this leaflet and DVD should be shared with patients. And what we've tested is a group consultation method. So the clinical nurse specialists from this service meet with a small number of the carers and take them through the leaflet, and they watch the DVD together and answer any questions that the carers may have. So it's not just about co-designing information leaflets and DVDs, it's about the process by which that knowledge is then transferred. And for those of you who are getting nervous, there haven't been any stats at all in this presentation. These are just some headline results. So we took the intervention that we developed, the leaflet and the DVD, and the group process of consultation, and we did a pre-post feasibility trial. I've just picked it the survey actually had 50 items. I've just picked a few out to give you a sense of some of the most interesting results. So in terms of how patients rank, how the carers rank the practical advice they received about managing cancer symptoms, the top row. At baseline, before the intervention, this is a 0 to 100 scale, they were rating that at 48.5, but at follow-up after they've been through this process of having the leaflet, the DVD, and the group consultation, they were ranking that practical advice at 69.8. And you can see in the control group, well, they didn't have the intervention, that it actually decreased from 50.1 to 43.9. So it seems like there might be something going on. This is a feasibility trial. There's quite a small number of patients. The second row of results around the information needs scale. This is a composite measure of 7 items, and you want the score to be low because that means you've got very few unmet information needs. It's a similar type of pattern in the intervention group, going down from 2.81 to 1.10, whereas in the control group, an increase pre and post. And then the final one, confidence in supporting patients if their health gets worse. This is a 1 to 10 scale. Again, similar kind of pattern. So it seems these are small numbers of patients, but it seems like they might be having quite significant effects in terms of how carers feel about some important aspects of looking after patients who are having outpatient chemotherapy. The final one I wanted to talk about was the Accelerated Experience-Based Co-Design project. Back to the survey results. So one of the questions we asked was, what are the weaknesses of the EBCD approach? Patient carers did not engage, didn't seem to be a problem. Staff did not engage, seemed to be more challenging. It cost too much. It was too complicated. But the one that seemed to be causing the most problems was it took too long. And anecdotally, that's what we were hearing from lots of EBCD implementations. This is fine. It's very valuable. The staff and the patients think it's great, but it just takes too long. That bit at the start where the researcher goes out and you collect all these filmed patient interviews and feed them back and produce the DVDs, it just takes too long. We need to be able to do this quicker. Louise Lowcock, who's here, and who is now working at Health Talk Online at the University of Oxford, but who I used to work with at Health Services Management Centre. So I met both Paul and Louise at the Health Services Management Centre. And I came up with this notion of, could we develop an accelerated form of experience-based co-design? So we retained all the 6 components of experience-based co-design, but we shortened the time frame. We did that by not employing Vicky. Sorry, Vicky. We just took the existing library of films that are at Health Talk Online. For those of you who don't know, Health Talk Online is a national archive of filmed interviews of patients. They've got 3,000 films split into different conditions. Could we use their existing films, do a quick secondary analysis of those, and produce a trigger film? And that would save us a lot of time, all of that time of Vicky going out to interview lots and lots of patients and carers and editing the film and sending them back. We could just use these trigger films from pre-existing material. What we also wanted to test was, could we, along with the King's Fund Toolkit, could we use internal local facilitators to drive this process so it wouldn't need external researchers to be there throughout the whole of the process? I would give a little bit of training to some local facilitators, senior nurses, and then we'd give them the King's Fund Toolkit. Would that be sufficient for them to be able to implement experience-based co-design successfully? And by doing that, we thought we could halve the overall cycle from 12, and normally takes 12 months to do EBCD, to 6 months. And we did that in 2 intensive care units and 2 lung cancer services at the Royal Berkshire Trust and the Royal Brompton Harefield. And Annette Boaz, who's now at St George's, observed how this affected the change process and outcomes. So we had a parallel evaluation stream. So essentially all we're doing is, at this third stage, instead of gathering the experiences of patients, we were just plugging in this trigger film from the existing National Archive, trying to do it much quicker. But in terms of the exercises that the patients went through, they looked exactly the same in terms of mapping the touch points, putting on their emotions onto those touch points, going through the same shared reflections about their experiences. The only change was in this shortening of the time it took to develop the trigger film. And what we found, and I was a bit surprised, because I'd seen how engaged all the patients and carers in the traditional experience-based co-design project, I'd seen how much individually they had got out of the process of having their stories filmed and seeing the DVDs, and then coming together to see each other's films. So I was a bit sceptical that we'd get quite enough patient-carer engagement with this process. But what we found was that the accelerated approach was readily accepted by patients, carers and staff. It did have some costs and benefits in terms, particularly of the local facilitators. We funded the local facilitators to work 2 days a week for 6 months on each of these implementations, and at times that was quite a burden. But it also did have benefits in terms of their personal development and the development of local quality improvement capacities in the participating trusts. And interestingly, in both trusts, they've now gone on to implement this approach in other services within their organisations. So what we found, as well as that it was generally acceptable, was similar types of co-design activities as we'd find in a traditional EBCD project. Some examples here from the ICU projects, an iPad application to assist ventilated patients communicate. Some lung cancer examples, a linked nurse scheme to improve cross-site working. So some of these are quite small, seemingly straightforward sort of improvements. Some of them are more complex across teams, across organisation redesigns. The other contribution I'll just briefly mention from the accelerated EBCD project, this was funded by the NIHR, is we did a very detailed bottom-up micro-costing of how much this type of intervention costs. And I think that's been seriously lacking in lots of the literature and work around improving patient experience. Real attention to actually beginning to put some figures onto how much this costs and the type of benefits that we're getting out of these approaches. So what we found in terms of the accelerated EBCD was that in terms of implementing it in one pathway, it comes out at about £28,500. Much of that cost, the first two lines on this table, are a one-off cost of developing the trigger film. Once you've developed the trigger film for intensive care units or lung cancers, then you've got the trigger film and you can use that in different services. But there is a one-off cost the first time you're developing a trigger film for a specific condition. But as you'll see, the largest cost comes around the internal facilitator. There's 2 days a week that we funded the internal facilitator to implement the EBCD approach. We've just written this up for the NIHR in the usual way. That's the team. I just wanted to share with you the feedback that we've just got from the editors and reviewers at the NIHR. So this is from the editor of the NIHR based on the report that we submitted to them. This is an exceptional work which has, in the editor's experience, achieved unprecedented scores from reviewers. It serves to restore their and others' faith in the power of applied qualitative research to shape both real knowledge production and beneficial change in the organisation of service delivery. And one of the reviewers said, the report displays qualities of imagination and rigour all too rare in qualitative evaluation studies. What is really important about it is that it knocks on the head the idea that patient surveys and questionnaires are the way forward in this very complex area. This report is a model of qualitative research excellence that is applicable to the lives of patients, carers and professional staff. And that feels much, much better than watching bodies pile up on the pavement in a summative evaluation. I just wanted to end with one final slide about where next. I think there's much more we can do around the cost and benefits of these types of co-design approaches. I think if lots of this work around improving patient experience is going to be taken really seriously, then we need to get much tougher with ourselves for doing that. Louise is keen to push acceleration even further. She now has some plans for Accelerated Plus. I'm sort of warily going along with that. We've learned an awful lot about implementing EBCD in different contexts and services, and we need to synthesize some of that, particularly the role of facilitators and the skills and capacities of internal facilitators. Work around developing this out into broader community-based interventions. Up to now, it's been within specific services, within silos. Can we take some of these co-design lessons, marry it up with co-production, community-based participatory research, and come up with some interesting ways of doing some community-based interventions? Those of you who were here for Jill Mabon's inaugural lecture earlier in the year would have heard about a study that she led looking at the associations between staff experiences and patient experiences, and I think it's fair to say when Paul and I started the experience-based co-design work, we thought it was an intervention that was going to improve both patient experience and staff experience. And what's happened over time is it has become an intervention to improve patient experiences and much less of a focus around staff experience. And I think we could do some further work around that. But I think most importantly for me is a closer collaboration again with designers, service design researchers, because back in 2003, 2004, that was the real impetus and prompt for this work. And I think over time, as we've got focused more and more on implementing it in healthcare contexts and disseminating that and developing the toolkits, I think we've drifted away from some of the design work and some of the service design research networks, and I think we need to get back to some of those. So I hope that's given you a sense of where experience-based co-design came from, how it's evolved over time and where it might go next, and certainly how it's shaped large parts of my career. But I wanted to end with this slide. These are my two sons. This is Sam and Alfie. who I try very hard to learn from and not judge. And in that respect, neither has ever been entered into a Bonnie baby competition. But I should say, because their grandparents are here, that if they had been, they almost certainly would have won. So, thank you very much for this. Yes, I'm happy to. Sorry. Yeah.
How much benefit would they get without actually going through the process?
I think virtually all of it is intrinsic to the process itself. So it is interesting you mentioned that. As I said, I'm going to Holland tomorrow, where they've just completed this project in 5 hospitals. And they've had an evaluation team from Erasmus studying that. And their main conclusion is it has to be the focus on, you have to take part in the process to get the benefits. That's not to say, because I think there's a temptation when you see these they're common kind of solutions that come out of these projects. So, you know, around privacy or around the physical environment. And so you begin to think, oh, we could just plug those, we could disseminate those and plug those in. But you have to go through the process. And I think particularly the co-design process. It's working in the co-design teams when the staff and patients come together. If you want to get those relational changes, relational differences, behavioural changes, then you have to go through that process. So it's not to say that you couldn't disseminate those solutions and they might have some effect, but I think it's all around taking part in the process.
Sort of following on from that, I think we shouldn't maybe undersell how much staff experience improves as a byproduct of getting involved in it, even if it's not aimed at improving staff experience. So I think if you just sort of parachuted in improvements that someone else has come up with, that would be one of the things that we'd miss. So we've had people coming up to us saying, it's the best thing I've done in 20 years of my career. And that kind of improvement, I think, is hugely important, even if it's not what we set out.
Yes. Yeah, and that it is common to, I mean, this was in a project team meeting, an end of project team meeting on the accelerated EBCD project. There was a very senior nurse who stood up in the middle of the group and said, the best thing I've done in 20 years, reminded me of why I came into nursing. But that tends to be sort of incidental. It is, I still think, I mean, it's great that it happened, but we could give a bigger focus in the co-design process to improving staff experiences as well.
Ben, thank you so much for a really exciting and moving lecture. I had the great pleasure of supervising an undergraduate student here at King's this year, Vanessa Duarca, who's looked at your research and the King's Fund Toolkit to propose a study using experience-based co-design for people with borderline personality disorder, who are a particularly hard-to-engage group, and a group where staff, particularly on inpatient acute mental health units, are actively hostile towards when they're admitted, even though crisis admissions are part of the NICE guidelines for borderline personality disorder. And her argument was, although it's quite a radical approach to use in that client group, it is the intrinsic value of the process, absolutely, that would make it for them. And I just wondered, in the survey of studies on whether people have been using it with hard-to-reach groups within cancer care, that you would imagine that the staff value patient voice quite strongly to start off with, and it's about discovering together what's wrong with the service, whereas in the client group Vanessa's looking at, it's not the case. People are suspicious of, mistrustful of, and devalue the voice of the patient.
Yeah. So a couple of things. We chose head and neck cancer as a pilot for a very specific reason. That is that these patients have a big personal investment in this service. They were much more likely to engage. It seemed silly to work downhill when we were testing this new intervention. So you're absolutely right. But I think what we've seen, and we've certainly seen it in the survey, is, for example, it's quite difficult to do this in emergency departments, as they did in Australia in 7 emergency departments. Patients aren't particularly wanting to hang around and take part in a co-design process in the way we did in the head and neck work. So I think there are adaptations you can make to the approach as long as you stick to the underpinning philosophy and some of the theories of design that are driving the process. But there are some really interesting projects going on in mental health. So Oxley's Trust has done some really interesting work on their inpatient ward. There's a big project in Australia looking at transitions in community mental health organisations. They've got funding for sort of $1.5 million Australian dollars to do this. So I'd be happy to share any of that. And some of that has come out of the survey. Yeah. Oh, sorry, I just meant to mention one other thing. Sorry, it just occurred to me. Your point about hard-to-reach groups. I think this is where this can link back into some of the community-based participatory research when we look at more community-based interventions. So, for example, Bob Williams in the school is very interested in doing some work with black fathers in deprived communities and the impact that their role has on the mental well-being of their children. And I think there are synergies between this kind of co-design approach that we've implemented in specific acute sector hospitals, but I think there's much we can take out into some of the community-based participatory research stuff. Yeah, I'm sure you have to share that. So I know of 5 implementations, as I say, in Oxley's. There's some work in Lancaster, and there's been a couple of projects in Australia. Yeah. Hello. Sorry.
As you know, I'm a big fan and we're trying hard to implement this, but in a cash-strapped NHS, how are we going to roll this out and mainstream it as an approach? Because I think what we're seeing is, really expenditure of $28,000 per service is not realistic across the board. Can you see any mechanism for being able to...
I'll ask you a couple of direct questions, Chris. How much is your trust spending on PPI and patient experience work at the moment? Do you know what the budget is? And how effective are those things that you're doing?
Yeah.
And if you can answer those 2 questions, then you can start.
Yeah, no, absolutely, but I'm fearful that the first question is not enough to fund some of this.
Mm-hmm.
How do you separate out or deal with people, the patients who want to be involved, who are just there to grind necks?
Well, I think there's always an issue with this type of work around, firstly, there's an issue about representativeness. What we're not seeking when we start these projects is a representative sample. We want some people who are going to engage with the project and be good informants to drive the change process. The other thing is, one of the reasons that we keep the patients and staff separate until quite late in the process is we want the patients to tell their individual stories, to then come together at that patient feedback event, share each other's stories and reflect on their experiences. And what we often find is when they're going through some of those touchpoint exercises, there may be those 1 or 2 patients who have a particular, as you say, axe to grind, a particular issue they want to talk about. One of the ones that occurs to me actually is from the original project with head and neck cancer. You might have seen it on the slide. There was one particular patient who had some big issues about her spiritual needs not being met. That wasn't an issue for any of the other patients in the room at that feedback event. So one of the key reasons why we're keen to have local service improvement facilitators running the implementation is that if someone has a genuine concern around their spiritual needs being met, that can be taken off and addressed through a different route, not through this shared reflection and identifying shared priorities to share with staff.